I'd like you to welcome Andrew Lee, who's the Federal Minister for Fraser, and he's going to do our official opening. Thank you, Andrew.
Well, thank you very much, Ellen, and can I thank Ellen and Christina for the chance to deliver the opening address. And like Auntie Agnes, can I also acknowledge that we're meeting here on the traditional lands of the Ngunnawal people and pay my respects to their elders, past and present. I have the pleasure of representing the north half of Canberra in the Federal Parliament. Canberra is, of course, the best city in Australia, stop laughing. And I hope that all of you will get a chance to get out and enjoy some of what this beautiful city has to offer over the coming days. I wanted this morning to share with you some stories that I think reflect the theme of this year's conference and remind us all of why effective knowledge exchange is so important. I want to start with a story from Don Berwick, who's a former paediatrician who ran the Institute for Healthcare Improvement, a non-profit organisation in Boston that provides grants to hospitals who are willing to try new ideas for improving medical practice. He was listed a decade ago by Modern Healthcare as the third most powerful person in US healthcare, after the secretaries of the Department of Health, the Department of Human Services, and the head of Medicare and Medicaid. And the reason that he is regarded as being so powerful is the way he thinks. And one of his favourite analogies comes from a forest fire in 1949 in Montana. It was a forest fire that engulfed a parachute brigade of firefighters. They found themselves caught by a fast-approaching forest fire with the only thing in front of them a 76-degree grade, a hill almost too steep for anyone to climb up. And their commander, a guy with the wonderfully euphonious name of Wag Dodge, realised that they weren't going to make it out of the forest fire. So instead of trying to run up the 76-degree grade, he took out some matches and set the grass in front of him on fire. The new fire took hold, and then he stepped into the middle of the burnt-out area, laid down and called on his men to join him. But most of his men didn't hear him. They were panicking too much. They either thought he was crazy or didn't get the message, and all but two of them died in the forest fire. Dodge survived virtually unharmed. And in lighting the fire, Dodge in 1949 created what's now known among firefighters as the escape fire. It's a standard part of firefighter training. Don Berwick tells the analogy to pass on the lesson that the firefighters' organisational training had unravelled, that they'd lost their ability to think coherently, to act together and recognise that they might need a new idea to save lives. As medicine grapples with the advancing complexity of knowledge and treatment, Berwick argues we need to do two things. Firstly, we need to measure ourselves, and secondly, we need to be more open about what we're doing, because openness drives improvement. And so improving policies and practices, like Wag Dodge, requires that we have to be open to new ideas, be willing to try new things to make health outcomes better. And in both cases, whether you're fighting fires or working in healthcare, doing the right thing can save lives. I think another story illustrates the importance of your conference theme here, the notion of informing, influencing and implementing. According to the US Centre for Disease Control, every year 2 million Americans acquire an infection while they're in hospital. Of those, 90,000 ultimately die from that infection. That's 90,000 Americans dying every year from a disease they caught in a place that was supposed to make them healthier. And For a layperson like me, these diseases, Creutzfeldt-Jakob disease, rabbit fever, norovirus and Klebsiella, sound a bit like something out of science fiction. But you in healthcare know that these are all too real. And you also know that for infection control teams, the problem isn't knowing what we need to do, it's implementing that in practice. The hardest part is getting clinicians to wash their hands. And the thing is, we've known the effectiveness of hand washing for over 150 years. It was a Viennese obstetrician called Ignaz Semmelweis who in 1847, at the tender age of 28, deduced that it was doctors who were to blame for what was then called childbed fever. It was then the leading cause of maternal death in childbirth in Vienna. This is well before antibiotics and even well before germ theory had become well advanced. And at the Viennese hospital where Semmelweis worked, the maternal death rate was 20%. 1 in 5 mothers who went in to deliver didn't come home. But he noticed that for mothers who delivered at home, the maternal death rate was just 1%. So the maternal death rate in a hospital was 20 times higher. And he deduced, you've got to say it's not a massive leap of logic, that it was the doctors that were causing the harm. It was the doctors that were carrying disease from patient to patient. So he had the right diagnosis, but his solution was just a little too crazy. He mandated that every doctor and every nurse scrub with a nail brush and chlorine between patients. If you've ever tried scrubbing your hands with either a nail brush or chlorine, you realise how painful it would be to do this once, let alone moving between every patient. But Semmelweis was a zealot about it. He'd stand next to the sink and he would berate anyone that didn't follow his requirements. And he got results. Childbed fever death rates in his ward fell from 20% to 1%, the same rate as for those giving birth at home. So this should have been incontrovertible proof for his ideas, right? Well, wrong. He didn't publish. He failed to inform, he failed to influence, and he failed to implement. When detractors attacked him, he came back with personal insults. And so he was unable to get this utterly sensible idea, hand washing between patients, spread into the broader medical community. Ultimately, Semmelweis is dismissed from his position as an obstetrician in Vienna, and he's avoided by staff at his new hospital in Pest. It's not until 2 decades later that Joseph Lister is able to have a much more powerful effect, because it's Lister who informs, influences and implements a much clearer, more persuasive and more respectful plea for antisepsis. As you know, the government, the Gillard government of which I'm a part, is recognising the importance of primary healthcare reform, and I'm telling stories this morning to demonstrate the value of primary healthcare and the importance of always looking at what we can do better. We've invested, as you know, billions of dollars to improve frontline GP and other primary healthcare services, where we've got an after-hours GP helpline in operation for over a year, and the Medicare locals that have already been mentioned are helping to address gaps in service delivery. We've boosted the primary healthcare workforce. There'll be 5,500 more GPs in the medical workforce over coming decades, and I'll come back to the importance of some of these healthcare reforms. But the importance of sharing ideas is I think, illustrated wonderfully by the tale of forceps. My third child is due in about 10 weeks. So my mind is very much on birth and also on how obstetrics can improve its practices. You, of course, as medical practitioners, know the wonderful paradox that is birth. In order to walk upright, you need a small, fixed, bony pelvis. In order to do all of the things we've evolved to do, you need a very large brain. And the combination of walking upright and having a large brain means that childbirth is painful and complicated. Essentially, due to evolution, our heads have grown almost too large to fit through a small pelvis. And the story of forceps is remarkable not only because of the number of lives that have been saved, but also because it's a story about a life-saving idea that was kept secret for more than 100 years. In the late 16th, early 17th century, Peter Chamberlain develops forceps. At the time, they looked like a big pair of metal salad tongs. But they're two blades, as they do today, fitted snugly around the baby's head, and they had the handles that lock together with a single screw in the middle so that the obstetrician doesn't, in pulling very hard backwards, apply too much force on the handles and therefore on the baby's skull. Chamberlain's a French Huguenot who delivered babies in London. He knew he was onto something with the instrument, and he knew he was onto something that could save lives of babies and their mothers. But because he couldn't get intellectual property protection for it, he kept forceps a family secret. So apparently every time he was called in to help a mother with obstructed labour, and he would only be called in late in the process because his fee was substantial, he would usher everyone out of the room. He'd cover the mother's lower half with a sheet or a blanket, so even she wouldn't be able to see the forceps. So no one knew what was going on as Chamberlain performed this medical miracle in the 17th century. At a time when he was able to save lives. But the result was he saved far too few lives. The Chamberlain family kept forceps, their secret, in their family for 3 generations. In 1670, Hugh Chamberlain tries and fails to sell the design of forceps to the French government. You can only imagine how many more French babies might have been saved if the French government had said yes. So late in his life, Hugh Chamberlain then sells on their family secret to an Amsterdam-based obstetrician, Roger Runhuizen, who then in turn keeps forceps a secret within his family for 60 more years. It's extraordinary and tragic all at the same time to know that forceps are kept as a family secret all the way until the 18th century. And then, of course, once other obstetricians hear about forceps, they gain widespread acceptance, and today no obstetrician is without a pair. So the story of forceps, in some sense, illustrates the importance not just of doing great research. And I know there's many great healthcare researchers in this room, but also sharing innovations, testing them, bringing them into everyday practice. One way of restating your motto of inform, influence and implement is if you've got a good idea, don't keep it a family secret. Collaboration and cooperation are other factors in successful bridging of research, policy and practice. And the golden 5 minutes is an example of how cooperation and collaboration have brought innovation to battlefield medicine. Colonel Ronald Bellamy, a surgeon with the US Army, went back and examined statistics from the Vietnam War. He found that the technologies for battlefield medicine appeared to be improving, and yet the share of the wounded who died hadn't been improving. If you were wounded on a battlefield in the 19th century, there was about a 50% chance you'd die. If you were wounded on the battlefield in World War II, there was about a 30% chance you'd die. If you're wounded on the battlefield in Korea or Vietnam, there's about a 1 in 4 chance you'd die, and that 1 in 4 continued all the way up to the wars of the 1990s. In some sense, the progress that had been made in battlefield medicine seemed to have stalled. And Bellamy noted that once soldiers got to surgical care, the death rate was only 3%. But although evacuation times had improved significantly, they still weren't fast enough. Civil surgeons or civilian surgeons talk about the golden hour in which trauma victims can be saved in an emergency department. But on a battlefield, the injuries are often much more traumatic, and so surgeons talk about their golden 5 minutes. Blood loss is often very severe on the battlefield, and so during the Iraq and Afghanistan conflicts, the US Army turned to a model called forward surgical teams. It's basically a military version of primary care. Little teams consisting of general surgeons, orthopaedic surgeons, nurse anaesthetists, nurses and support staff, and they travel out in Humvees out to the battlefield among the troops. And there, in the midst of battle, they set up what they call deployable rapid assembly shelters, or DRASH tents, and they form a 900 square foot hospital facility. They're supplied with an arsenal of equipment which is aimed to perform surgical care but not using many of the careful techniques that have been developed for hospitals. So as a result, because they're setting up more simpler strategies, they're able to go from sitting in their Humvee to a fully functional hospital with 2 operational tables and 4 ventilator-equipped recovery beds in the space of 2 hours. But the US military realised soon after the rollout of these DRASH teams during the Iraq War that they needed to change their protocols for when injured victims were brought in. They realised that they had limited supplies and so could only provide a short period of operative care and no more than 6 hours of post-operative care. So they changed their focus from one of entirely treating someone to damage control rather than definitive repair. They pack off a liver with gauze pads to stop the bleeding, put in temporary plastic tubes in bleeding arteries to shunt the blood past lacerations. They'd staple off perforated bowels, wash out dirty wounds, and mostly try and keep operations under 2 hours. And then the soldier, once stabilised, but often still under a general anaesthetic, would be shipped off to the next level of care. This might sound straightforward now, but it was pretty radical to the surgeons who were doing it. Surgeons who had been trained in civilian hospitals were trained with a maxim of trust no one, fix up your patient, provide definitive care. But it was the wrong approach for the battlefield. As a result now, the average time from an injured soldier being injured on the battlefields of Iraq or Afghanistan to arriving in a facility like Walter Reed in the United States is 4 days. Back in Vietnam, it was 45 days. I told you before the US military had the share of wounded who died stuck at 25% for most of the post-World War II period. It's now down to 10%. If you're injured on the battlefield, you now have just a 1 in 10 chance of dying, and that's because they changed the way in which they provided this forward medicine. They did so working together with researchers, policymakers, practitioners, even politicians, in delivering the best possible practice and recognising that the old way of doing things, which may work in a civilian context, doesn't work on the battlefields. These insights have flowed through to the way in which Australia provides battlefield medicine. It ensures that Australian lives are saved in Afghanistan. Back here in Australia, we're working with GPs and other health professionals to provide arrangements for better coordinated care. One of the areas in which this is critical is in the management of diabetes. We're working to develop a national strategic framework for GP and primary health care, and that'll be informed by bilateral work on state-specific plans. We're providing over $100 million for primary care infrastructure grants, and approximately half of those dedicated to regional Australia. We're also adding more incentives to invest in primary health care as the federal government moves towards funding half the growth in hospital expenditure. The aim of those reforms back home is to provide better and more accessible services to patients in the community. We want to take pressure off hospitals because when you look at those international stats, there are too many Australians in hospitals compared to other countries. We want to better support the hard-working primary healthcare professionals. The final set of stories I want to tell you relate to randomised trials. I'm a bit of a zealot for randomised trials, and one of my great heroes in this regard is Archie Cochrane. Cochrane's a tireless campaigner for better evidence in medicine, and many of you would be aware of of effectiveness and efficiency, published by Cochrane in 1972, that then inspires the creation of the Cochrane Library. The Cochrane Library now builds on the voluntary efforts of over 28,000 medical researchers to gather together the best available evidence on effective treatments. It's a useful antidote to what used to be the way, the God complex of doctors who felt that they alone, through introspection, could work out what was going to be best for the patient. But the story I wanted to tell today isn't about the creation of the Cochrane collaboration, extraordinary as that is. It's a story about Cochrane's first randomised trial. Cochrane was a prisoner of war in a German camp in Salonika. And while he was there, the prisoners were struck by a severe outbreak of a condition causing pitting edema. Cochrane didn't know what illness he was dealing with. He was suffering himself, and so he improvised a trial with only 2 possible treatments at his disposal. He had his personal store of vitamin C tablets, and because there were Brits in the camp, he had a store of Marmite. So there are his 2 treatments, vitamin C and Marmite. Cochrane took prisoners of war who were suffering from the condition causing pitting edema and divided 20 severe cases into 2 groups of 10. He found that after 4 days, 8 out of the 10 Marmite group felt better. Nobody in the vitamin C group felt better. And so he meticulously graphed out the data and took it to the Germans who were running the camp. Now, this was a German prisoner of war camp, and the Germans, let's face it, were not famous in World War II for being gentle camp guards. Cochrane tells the story of one camp guard who had heard suspicious laughter in the latrines and had responded by throwing a grenade into the latrines. Cochrane himself had been one of those who had to clean up afterwards. But Cochrane gave the results to a German doctor who looked at the jaundiced, half-starved, swollen, flame-bearded Scot and looked at the data and retiring to his room in tears from the hopelessness of it all, the doctor demanded of his superiors that more generous supplies of yeast be supplied to the camp. They were, and the prisoners started to recover. Now, people often say that randomising is somehow cold, that it's unfeeling. It's splitting people into 2 groups, treatment and control with a toss of a coin. The results of an Excel spreadsheet determine your treatment. But I regard it as anything but. I think that randomising is a way of bringing out the best evidence and a way of treating those most in need. And if you want to know that Cochrane was driven by a deep inner passion for healthcare, try this story. Late in the war, Cochrane was interned in Elsterhorst, a hospital for prisoners of war. There was a young Russian soldier who was brought into his ward one night. Cochrane said the man was in awful condition, screaming incessantly. And he took him into his own room so the Russian soldier didn't wake the other patients. He didn't have any morphine, he just had aspirin. And this is how Cochrane tells the story. I knew very little Russian then, and there was no one in the ward who did. I finally, instinctively, sat down on the bed and took him in my arms, and the screaming stopped at once. He died peacefully in my arms a few hours later. It was not the pleurisy that caused the screaming, but loneliness. It was a wonderful education about the care of the dying. And I think it's that spirit, it's that Archie Cochrane that ought to drive all of us in looking for better solutions. In the area of social policy, I moved a motion in Parliament in February last year that we ought to have more randomised controlled trials, taking a leaf from the medical book to better evaluate government policies. It's challenging in the area of social policy. I think a lot of people believe we can do before-after evaluations or compare across regions. But randomising provides much better results and often results that are counterintuitive. One of the examples some of you might know about was a randomised trial of adults with severe head injuries who had been treated for decades using steroidal injections. In principle, that made perfect sense. Steroids reduced swelling. It was believed that the swelling inside the skull killed people with head injuries by crushing their brain. And it was tested using a randomised trial a decade ago. And it was a randomised trial that was very hard to get off the ground. Many people opposed it. They said, we know that steroids are effective. But when the results are published in 2005, it showed exactly the opposite. People getting steroid injections for head injuries were more likely to die. What was a routine treatment accepted across the profession was actually wrong. And in fact, the results were so clear that this was one of those trials that was stopped early to cease causing additional harm to participants. Also in the area, area of head injuries, one of my favourite examples of randomised trials is Alan Garner's head injury retrieval trial, which is aimed at answering the question, if a patient has a serious head injury, are you better sending an ambulance with paramedics or a helicopter with a neurosurgeon? And so through the Sydney region, people who have received head injuries and for whom somebody calls 000, because if you're a participant in the trial, you're not in a state to call 000, you are placed into this randomised trial. A 000 operator effectively tosses a coin, and that coin effectively determines whether or not the helicopter with the neurosurgeon or the ambulance with the paramedics goes out. And what I loved about this randomised trial, when I spoke to Alan Garner about it, was his sense of modesty about it. He told me, we think it'll work, but so far we've only got data from cohort studies. He said, like any medical intervention, there's even a possibility that sending a doctor could make things worse. I don't have any evidence. I don't think that's the case, but until the trial ends, I don't have evidence either way. And that lack of ideology, that lack of a sense of zealous righteousness is to me wonderfully refreshing in the area of health policy as it is in other areas. So I should shortly leave you to get on with your day. I understand the Primary Healthcare Research and Information Services Award for Best Poster is highly sought after. I've even had a look at some of the research being presented in the poster sessions. I was intrigued and interested by the research. My eye was caught by topics like put the head back on the body, connecting people with little or no speech to GPs via broadband. Close to my heart as part of a government that's rolling out the national broadband network. A topic called what do we mean by patient engagement? Another called bridging the gap between thinking and doing. My own experience as an academic in the field of economics is very much that posters are a great way of facilitating knowledge exchange. They're a terrific, quick way of conveying information, and better yet if the poster writer is standing next to it to answer questions. I know you'll all get great value from them, and I wish all the entrants the best in winning the coveted award for Best Poster. And apart from doing a little storytelling this morning, the other honour I have is to launch the 2012 edition of Snapshot. The snapshots in the this primary health care research publication demonstrate the importance and value of the research to improving health outcomes for Australians. There's 11 research projects showing us how private healthcare research provides policy and practice relevant findings specific to the health reform agenda in Australia's first national primary healthcare strategy. Unlike the posters, what impressed me most about the snapshot was the range of health priorities covered. Priorities in healthcare the government's focused on in improving patient outcomes and service delivery. Priorities such as prevention, chronic disease care, integrative health care, smoking cessation and the needs of caregivers. And the government's primary healthcare research, evaluation and development strategy helps facilitate and support knowledge exchange. I want to congratulate Ellen and all those involved in producing Snapshot 2012 on another outstanding publication. Now, as all of you know, one ought to acknowledge sources in any context, and I would commend to you Atul Gawanda's book, Better, A Surgeon's Notes and Performance, for his stories of wag dodge, handwashing, forceps and battlefield medicine. I think much of what Gawanda talks about reflects on what the conference and you as primary healthcare professionals are seeking to achieve. The amazing life of Archie Cochrane is told in Tim Harford's terrific book, Adapt, Why Success Always Starts with Failure, a terrific title that I think has a great lesson for all of us involved in research, policy and practice. A bridge connecting research, policy and practice is really critical because building better outcomes through better performance only happens when you're informed by best practice. It's been a central part of what got me involved in public life and something I am passionate about and advocate in Parliament. So I wish you successful knowledge exchanges in the next 2.5 days. I happily declare Snapshot 2012 launched and wish it a safe and speedy voyage. Thanks very much.
Thank you, Andrew, and on behalf of the conference, we really appreciate you having been here and telling us such wonderful stories.
Thanks very much.
You're welcome.